welcome to another episode of Talk on Things and Stuff, where today we're going to be taking a look at some of the issues that are covered in the second of the Swedish documentary series that have recently been posted to the YouTube channel. In the last episode, we were introduced to the subject of medically, either through hormones or surgery, treating children who present with gender dysphoria and some of the issues involved in that. Remember, this documentary series eventually led to Sweden putting the brakes on and reversing course on their trajectory for allowing more and more of these interventions with fewer and fewer safeguards. The second of the documentaries comes out in the midst of a political battle in Sweden, where activists are promoting a bill which will allow children as young as 15 years old to get gender-affirming surgery without parental consent. And there's a lot of debate about whether or not that is wise on the side of the people who are hesitant to go that direction. And then for the activists, the issue of suicidality among teens who are waiting for therapy being used as the justification. And so on one side, you'll see people saying so many people are committing suicide while they're waiting for assessment, while they're waiting for treatment, that we need to remove all barriers just to allow them to have the will to live. And so I think the people on the other side are saying, well, if we remove all of those barriers, we're going to increase the number of people who will get these interventions, which are inherently irreversible, but they may be getting them in the midst of a psychological crisis that would distort their judgment, their thinking. They're already too young in order to consent, in order to understand the full ramifications of these procedures. And so rather than remove safeguards, we need to add safeguards. It's a heated debate, and you'll find those two conflicting issues at the center of any nation, any state that's trying to consider these options. And if you've been watching my channel over the past few months, you've seen a number of the hearings here in the United States where various states that are considering changing the safeguards in place around this issue have asked witnesses to come and testify. And a lot of these questions come up in that context as well. So if you haven't yet had a chance to watch these documentaries, this is the second of the documentary. I encourage you to pause this video here, go back and watch both the first documentary and our first discussion if you have time for that, as well as the second documentary, because it's this building kind of library of information in your head where you understand the various sides of the debate and the various nuances that will really prepare you to understand things going forward. And this week, where we're issuing each of these documentaries, is in preparation for us going through testimony by testimony the Ohio debates around this issue, because it's just a really fascinating insight into the types of things that people have to consider when you're a government or a medical health institution considering these interventions. It's really important to understand both sides of the issue so that you can try to make the best decision. And I think that having this context of what's happening in Europe that has led them to reverse course is really important. It really helps you understand the framing of the responses by some of the witnesses in the state hearings. And can also, if you know what's gone on in Europe, you can also see where there's some gaps in knowledge in the way that the discussion is happening here stateside. So, all right, with that being said, I do want to open up our phone lines because I think a big value in some of this is if you have personal experience in this, either with a family member or yourself who has gone through this issue, then we'd love to hear from you. So if you want to call in whenever you get inspired to do that, the number that you can call that will reach us for this discussion is 210-422-2222. And with that being said, let's take a look at some of the issues that were brought up in the second part of the Trans Train documentary series that was released in Sweden in 2020, I believe is the year that this came out. It may have been 2019. I don't remember exactly. Okay, so let's take a look. Okay, so we're going to start out. Each of these documentaries is really powerful in that they choose a very personal narrative story to frame the discussion around. And in the case of episode 2, they frame the discussion around the experience of Johanna. Now, you've seen on this channel discussions with detransitioners who have entered the medical system and gone through medical or surgical transition and decided that it wasn't for them in reverse course. Johanna is different because she came out as trans and then applied to enter the medicalization pathway in Sweden, but because it's a nationalized health system, there's one center that does all the treatment, and they've seen a huge flood of people applying for that assessment and treatment. There's a waiting list, and the waiting list in her case was something like 18 months long. And so she got on board to be assessed so that she could get hormones and surgery. She was absolutely convinced that's what she wanted, but that waiting time gave her an opportunity to slow down a bit and did what many on this side of the pond are trying to do, which is to say, slow down a little bit, let some time happen. And we get to see as she reflects on her experiences before she came out as trans in conversational therapy with a therapist, where they're allowed to explore why she feels this way and possibilities of things other than being trans are explored, that she eventually decides to reverse course. Now, the reason that's an important story is because that process of talking through other psychological issues, other bits of the complexity of her personal story to see if there are other considerations other than the possibility of being trans, that process is being framed as deconversion therapy and lumped into the same category as gay deconversion therapy. And so there are laws that would actually, in the mind of many clinicians, prevent them from going down that pathway of conversational psychotherapy to look at other issues. And so when we see that her story ends out differently than somebody who immediately goes down the affirming pathway, if there was no waiting list, then we can see how her life after this, adolescent turmoil and turbulence would be very different if she had had surgery or hormone therapy. So let's go ahead and start with Johanna's story. I've talked to some people and not others about how I've been questioning my gender identity for some time. Johanna is 19 and in her final year of high school. She's one of the young people who have sought gender-affirming care. She came out as Casper, but found herself in limbo when she sought help. At 17, she was too old for the kid team, but too young for ANOVA. She wanted to take testosterone and have a mastectomy, but had to wait a whole year before her assessment began. I had to wait a long time and went around like I got so frustrated with the wait. I just wanted to get started taking testosterone and having my evaluation. I think that's a really important point here to see how the sense of urgency is something that you will hear again and again, both from activists who are advocating to remove as many safeguards as possible, but they don't call them safeguards, they'll call them gatekeeping. And the idea is that we've got to have an affirmative only perspective in how we respond to these children who are in urgent need. And the reason for this urgency usually has to do with the threat of suicide, which this documentary episode covers and we'll get to in a little bit. But when you study suicidality, there's always a bunch of journalistic recommendations. If you're going to cover the subject of suicide, you have to have these disclaimers, and you have to be very careful about how you cover suicide, the way that you frame it if you're a journalist, because there is a social contagion component of that. And it seems to disproportionately affect young girls. There's historical episodes in, I think it was Japan, where there was a story of a suicide that was covered in a certain way, and then they started to see an epidemic of suicides happen. Stories about people jumping from bridges The way that news journalists covered it led to more of the same thing happening. So it's always very touch and go, or you have to be very careful about how you frame and present the issue of suicide. Well, in the world of social media, where you have TikTokers and Tumblr commenters talking about how they feel about things, the presence of suicide, the threat of suicide, it can kind of have the same sort of effects. And there's no journalistic safeguards in how you present or frame those issues or whether or not you cover them at all. And so we have a whole generation of young people who are being exposed to things that we know already have kind of a social contagion component to them, but it's kind of the Wild West in the way that they're presented and talked about, if you think about TikTokers and everything. So when you start to listen to detransitioners talk about how the issue of suicide affected them, how it altered and framed their judgments, you can see that there's some measure of influence that happens from social media. And it all adds up to increasing the urgency of it. In some cases, you'll see some people say that you can use the threat of suicide to get what you want. And there's a popular, it was popular at the time, or at least controversial, that a mental health professional who was advising parents and people about how to get access to medical care in Canada, one of the things that he said was, if there's a dramatic event, like if the threat of suicide, well, then that will make sure that you get what you want. And I'll post a link to that audio recording so you can see how that kind of blows up, because people are using this threat of suicide to increase the pressure on lawmakers, increase the pressure on medical professionals to try to get people what they want, because there is this sense of urgency. They want what they want. And anyone that would ask questions, say, hold on a bit, or say, let's consider other issues going on in your life, is framed as someone who is trying to be a gatekeeper. And the only reason for that gatekeeping can be because they don't agree with your identity as a trans person. They must be hateful or bigoted or have some other problematic part of them. And that's something that, it takes some time to dig through. And this documentary is doing a good job of showing how she, at the moment, felt that same sense of urgency. And if the system was in place at that time to immediately respond to her demands of mastectomy and testosterone, then she would have gone down a pathway that she ultimately did not go down, because there was this waiting period combined with talk therapy, with exploratory psychotherapy and conversation. Okay, so let's keep going.
I had read online about transgenderism. I watched videos on YouTube. There's a community that I got involved in. Then I watched videos about how to know if you are trans. Just the fact that you're watching this says a lot, they said. Then I met a friend who is trans, and he...
Okay, so I do want to comment real briefly. If you want to see the type of information that children may be exposed to, just go to TikTok or to YouTube or to Tumblr or any of the most prominent social media sites and do a Google search for how to know if I'm trans, and watch some of the videos, watch the way the question is answered. And then ask yourself, if you, as a teenager, in the midst of puberty, in the midst of all of the uncertainty and self-consciousness and doubt and insecurity, how you would have been able to take that information and distinguish between information coming from amateur sources versus information coming from more professional sources. It's a really difficult forest to navigate for adults, even, much less for kids who don't have a whole bunch of life experience behind them. But that's the type of influence that are dramatically affecting the trajectory of many kids in those moments of adolescence. And it certainly affected Johanna, as she's relating here. Now she's going to talk about an individual that she met and how it affected her. So I'll back it up just a little bit.
The fact that you're watching this says a lot, they said. Then I met a friend who is trans, and he said... He described how happy he was. Since getting my mastectomy, life has just gotten better. I thought, can my life also get that good? What was so appealing? I'd hope I'd feel good in my body. I hoped it wouldn't be a struggle to feel good in my body. That the mastectomy would make me like my body. That testosterone would make me enjoy living in my body. Because I hadn't enjoyed living in my body. I have had since I was maybe 9 or 10. I've had problems with my body. Then I turned 15 and developed anorexia. And I started hating my body with a vengeance. I starved myself. I didn't think I deserved to eat or deserved to feel good. It became such a natural way of thinking. I knew what I wanted. The assessment was just a bump in the road.
So if you remember from episode 1, one of the major takeaway points from it was that while historically treatment for trans individuals was centered on middle-aged men, and that was the population that were seeking therapy for gender dysphoria, we've, in the most recent decades, started to see a flood of particularly young women, either teenagers or young adult women, who are presenting with gender dysphoria for treatment. And there was a very different profile of patients, including many comorbid psychological issues. And of the ones that they listed, it included depression, anxiety, autism, but also anorexia, which is kind of in this category of body dysmorphia. And the story is particularly interesting because it's showing an example of one of those patients who, when they present to the clinic, have a history of another complex psychological issue, which may be playing a role in the reason that they are experiencing gender dysphoria. And if you compare the two different pathways, the gender affirmation only pathway, where you simply ask what their identity is and then initiate the process of hormonal, well, first surgical or social transition, and then puberty blockers, cross-sex hormones, and sex reassignment surgery, versus the watchful waiting technique, where you start first to explore those other issues, and you can see where it ultimately will lead the patient potentially down different pathways. That is kind of the crux of the matter here. Comparing these two different things, what has worked traditionally in terms of this watchful waiting and exploratory psychotherapy or conversation therapy, versus immediate affirmation and starting on the trans train of medicalization. So the other thing that was in that segment was the fact that she met somebody, and that person was giving a very positive report about the effect of a double mastectomy on their lives. And so they saw that single data point and thought, well, maybe that will have the same effect for me. And this is an issue that you see in a lot of the literature that is coming out on this subject, is that medical or surgical intervention will be applied to a patient population without a control group, and then they will report positive findings in what is ultimately a relatively short follow-up time, on the order of 18 months, for example. And they'll say, look, there's positive results after 18 months. When these changes, will be living with these patients throughout their entire lives. In the case of somebody who starts on testosterone as a trans man, they will be receiving testosterone and having to go for regular checkups throughout their entire life. That's medication and a footprint on the medical services of a community that extends throughout their entire life that would not be there otherwise. And you know, it carries a toll both in their personal life as well as the medical system itself. And these decisions should not be rushed into, particularly at one of the most turbulent points in an individual's life. The The argument against this affirmation only model is not that transition should never take place. It's just that it needs to be very carefully entered into, and you have to look at the complex psychological landscape of an individual. You can't simply be affirmative only. And where that really comes into contrast is where you see that the justification for these interventions, when you ask the clinics here, stateside or otherwise, where do you get your protocols on for diagnosing someone and for initiating therapy? And they'll say, well, we follow international guidelines, or we follow professional society guidelines. And so then you look at those guidelines, and they will generally, if it's the endocrine society, if it's the pediatric society, they'll say, well, we defer to WPATH. And WPATH, when you look at their justification, they refer to studies, specifically the Dutch protocol and the Dutch studies starting in 2014. And those studies had very specific requirements for who could receive therapy and who couldn't. And if you had these complex psychological comorbidities like anorexia, you would not have qualified to go through puberty blockers and cross-sex hormones. And so just because a clinic or a society says that they follow international guidelines, that doesn't necessarily mean that the protocols that are being applied are sound when you look at how the studies were originally designed. So, okay, let's keep going.
After that, I'd get testosterone, have a mastectomy, and be happy. Did you consider whether it was right for you if you'd really be happier? I didn't have the energy to think about that, because, not to begin with, I so wanted it to be true, I really did, that this was my path to happiness. So I thought, if I feel better after making the transition, then I can live and be happy. And if I don't feel better, then I'll kill myself. In December, Johanna finally got to visit the Anova clinic for adults. The only people I trusted to determine if I was trans was the Anova clinic. And their first question was,
okay, so that statement is actually really important. She's saying that she was looking to this clinic for confirmation of the diagnosis. She suspected that she was trans, but she was looking for them to assess her. And if you're in the medical profession and you're trained in mental health, then there's something, there are criteria for diagnoses. So whether it's major depressive disorder or an anxiety disorder, you're able to look up in the DSM or other references and see what is essentially a checklist of criteria that would allow a patient to cross a threshold to meet the diagnosis. And the controversy that seems to be arising on this issue of whether or not somebody is trans is that there is no criteria that seems to be consistently applied when you look at how the clinics are doing it. There's several stories that are coming out of families where they'll go to a gender clinic or they'll go to a service provider looking for the question of how to deal with the child's dysphoria. And the clinician will simply ask the child, do you feel that you're a girl or a boy? And if it's the opposite gender of what they are, then they'll turn to the parents and say, congratulations, you have a son, and we need to only affirm it. And the only criteria is what the identification of the patient is. There's no further exploration. Now, this is not uniform. There are clinics that do more exploration, but the point of having this conversation about how we initiate that therapy is because if there is no standard that people are consistently applying to when to initiate these irreversible therapies, then clinics and facilities that are, that have fewer safeguards and fewer gatekeeping will start, they'll become known and people will seek them out. And then we'll end up having people who are damaged by a system that's not consistently applying the principles of ethical and evidence-based practice. So when she was looking to the clinic for that diagnosis, there's the expectation that they will do a rigorous assessment, not just of her self-report of being trans, but of her entire complex psychological landscape to see if this really is the issue or if there are other things that should take place. Now, in those Dutch studies where children were presenting in adolescence with the history of having felt gender dysphoria since they were very young kids, if they had issues like her with anorexia and past suicide attempts, then they would not immediately put them on the protocol. Those other issues would have to be addressed first. And some of the controversy that is happening is that the doctors that were originally involved in that Dutch study have raised alarm bells and said the way that our protocol is being implemented worldwide is not consistent with how we originally designed it. And we're really concerned that people are being put on this trans train of intervention inappropriately as a result of that. And this is just one of those symptoms. So, all right. Let's keep going.
When do you want to start on testosterone? Coming out as trans was my last hope. I recovered from anorexia, but I wasn't happy. I stopped self-harming, but it didn't make me happy. If this didn't work, nothing would. I'll try this, and if it doesn't work, then nothing works for me, and I might as well die. Johanna had to wait a year to get into the Inova clinic.
Just want to point out that she said that when she finally got to the clinic, their first question was, when do you want to start testosterone? And the implication there is that they didn't explore her background. They didn't explore the other facets of who she was and her experience with anorexia and past self-harming. All they did was listen to her self-identification as trans and say, when should we start the therapy? And that is in contrast to what she did during that waiting period, which is what we're going to cover now.
At her first visit, the doctor brought up testosterone. Inova emphasizes that no medical treatment begins before diagnosis. Johanna later dropped out of the assessment. The wait to begin the assessment led to an unexpected consequence. While she waited, she began seeing a psychologist. He told me, because I've had difficult body-related experiences, I've had an eating disorder and a problematic relationship with my body. And he said, what if it isn't being trans that caused your anorexia? Because that's what I told myself. I got anorexia because I'm trans. But he made me turn it around. What if I say that I'm trans because I still have residual body dysmorphia from the anorexia? I was looking at it backwards. It was an eye-opener for me. Healthcare professionals should be the impartial ones who dare to say, you're trans or you're not trans. The role of healthcare professionals is to diagnose, not to be nice. The first person I told that I couldn't identify as trans anymore was my psychologist, and I cried and I cried, and I said, I don't think I can call myself a man anymore. And I cried out of grief. It was so tragic to realize that this wasn't my quick fix. This wasn't the solution for me, probably, as it looks now. And I so wanted it to be. I so wanted this to be my happy ending. And coming to that realization hurt so much. The first time, I was proud to come out. The second time, it was an apology. I thought I was transgender because my body anxiety and masculine clothes, those two things together equaled transgender. What do you feel has changed now? Nothing on that plane. I'm trying to work on body acceptance is the word, but I still think before I was firmly convinced that sex reassignment was the answer. When I wanted to come out as a girl again,
I want to have a comment about that statement there that she made, that before she was firmly convinced that sex reassignment was the answer. And if you've been a parent of teenagers, you've probably seen what it's like for having to have a very headstrong teenager who feels very firmly about a particular thing. And particularly when it's something that may not be in agreement with their parents, there's that conflict that exists there. And that will exist in something not related to gender identity, not having all of this social baggage that goes along with it. You know, even something where if a parent disagrees, you can't immediately call them an ignorant, phobic, problematic person. And so you throw in all of that heavy baggage from all of the moral implications of wanting to put the brakes on something like this, wanting to slow down, and it can be, you know, it can cause a lot of conflict within an internal family. And not everybody in the family may see things eye to eye. And that brings up another dimension of the Dutch protocol, which is that they looked not at just the family, but at the family dynamic as well. So if the patient was very early in childhood identifying as trans, and if they didn't have any of these complex psychological comorbidities, they also needed to be in a family in which everybody was on board and everybody agreed and supported. If there was toxic family dynamics, if everybody was not on board, if they didn't have the support, then they also wouldn't qualify for that study. So anytime that you hear the report that, well, studies have shown that going down this pathway of medical and surgical intervention produces better results in the long term, you just have to remember that those studies are crafted with very specific exclusion and exclusion criteria. And if you're not applying those interventions to the same population, then you cannot have any confidence that you're going to get the same level of results. And that is assuming that the positive results and the interpretation of the data was actually correct. And the problem with this, with the Dutch study in particular, is that when you look at what the data points are that led them to say that there was improvement of body dysmorphia, that has a whole host of other issues as well, but we'll get to that in a future episode. So this is the last segment of Johanna's story, and let's finish it out.
I was very close to killing myself. I thought, I can't stand that everyone knows I was wrong. So many times I felt I couldn't bear that burden. I couldn't say I was wrong to the extent that I was. It was the shame of it that scared me the most. It felt strange to be called a girl and Johanna. But I thought that I have to try. I still feel like that. Right now I'm okay, but I can still change my mind. I think that's my salvation in this. That I don't have to have a permanent answer, like when I came out as trans. When I came out as a guy, it was like for eternity or not at all. Now I feel this is how I feel now, and I don't have to decide more than that.
All right. The inclusion of Johanna's story frames this episode so powerfully. And, you know, when you listen to that last segment where she talks about as difficult as it was to come out as trans initially, it was even more difficult to reverse that decision. And this is a very common theme when you listen to detransitioners talk about what it was like to back away from the direction that they were going in trans, because there are so many powerful love bombing type forces when you first come out as trans. Everybody celebrates you for being brave, for being courageous, for making that decision, and for being public about it. Many times you've had a lot of conflict with your family because they're not using the right pronouns or they're not using the right name. And so you've engaged them and created some difficulty in those relationships. And if you later then reverse course, then it's admitting that you were wrong, and it feels personally shameful to them. And what she talked about right there, which is that she felt suicidal because of the shame of detransitioning, is not an uncommon story. And it's another reason why, if there is a medical body that is presenting guidelines for transition, they should ethically and responsibly also include guidelines for detransition, which should be that if somebody does decide to detransition, there should be some mental health support too, because that can also be a very difficult process and carry a heavy burden that may also have the same risks of suicidality. And that's where a lot of people have pointed out that WPATH, the international body that tries to set the standards and to which all the professional societies turn, barely treats the issue of detransition at all. If you look at their most recent Standards of Care 8, they don't even describe detransition as detransition. They describe it as retransition, and it really does not address the issue of the psychological burden and toll and experience of detransitioning. And so hopefully that's something that will happen. Okay. So and what we just saw in Johanna's story was basically taking all the little various clips that are peppered throughout the episode and putting them together so you can kind of follow her journey in one go. But I definitely encourage you to watch the documentary, because there's so many important points brought up along the way that put some of her experience in context. Again, the overriding theme, though, is that for her, if she had immediately gone down the affirmation pathway of hormones and surgery, then she would have had irreversible changes that ultimately would not address her issue, because as the conversational therapy was able to explore in her story, her issue was not trans in the way that would have justified those surgeries. She had these complex issues with body dysmorphia and anorexia that were the source of her distress. Okay. In the comments, we have Joanna that says WPATH also dropped the proposed chapter on ethics and kept the chapter on eunuchs. And that has been a very significant sticking point in the people that are looking to WPATH to see if they're going to start to address some of the more complex issues that we're learning as we see the experience of detransitioners and what they mean to what is ultimately a failure on the part of the medical system to apply these modes of therapy to a complex patient group. So that's a very good point. All right, if you want to join in the conversation, the number is on the screen, 210-422-2222. We'd love to hear any thoughts that you have to say or share with us as you have watched these documentary series. With that being said, let's go ahead and move to our next slide.
I've talked to some people.
Which is, okay, so in the last episode, they showed the curves of the patients presenting to the gender clinics in Sweden. And we saw that from the 2012-2013 era, the slope of the curve was just going up and up and up, and particularly among young women. And the clinicians there were saying, well, we don't really know. We don't understand why. This new patient group seems to be of a very different profile from the patient groups that we have historically studied. And that is because not only are there a disproportionate number of women, but there's also a disproportionate number of women who present with anxiety, depression, autism, all of these other complex issues. And so normally you would want to do some sort of study to figure out why. What is the unifying factor that seems to be an explanation why these patients are here? Because that may inform the therapy that you take. Because if there is a factor other than simple, uncomplicated gender dysphoria, then you may need to make sure that your therapies adapt to address those other factors. That requires people to kind of understand why there's this upsurge. And they treat this a little bit in the second documentary. At one point, they are speaking to the head of the Anova clinic, which is the adult clinic there in Sweden, and they ask her why the upsurge. And I believe that's the next clip that we have here. So let's take a look at that.
The KID team in Stockholm treats a majority.
Okay, I was wrong. It's the KID team, which is the child and adolescent team, not the adult team.
Of transgender youths. My name is Luis Frisian, and I'm the head of the KID team, the team for gender identity evaluations in child and adolescent psychiatry. What is your perspective on the increase in gender dysphoria patients seeking help from you? I'm just as baffled as everyone else. We don't understand why it is. Everyone in the world who works with these patients wonders the same thing. I think it's likely that we're starting to see the iceberg. From only seeing the tip, now we see a majority of those with gender dysphoria.
All right, the point that she's making there is one of the most common responses that you'll get to the question of why do we have such a flood of people presenting with gender dysphoria now? And people will say, well, these people have always existed. It's just that they've had to keep themselves hidden. They've had to keep their struggle private because society has not been accepting of their story. And there's a couple of points that you can raise in response to that point out that it may not be as simple as that. If it was simply that society is more accepting now, then you would expect similar rates of men and women coming out and the rest of the iceberg being revealed. But that's not actually what's happening. We're seeing a hugely disproportionate number of young women that are presenting with gender dysphoria. And so the picture doesn't exactly paint that of just societies being more accepting. And that's one of the things that they cover later in the documentary. Okay, so let's keep going.
What's the risk if they don't get treatment? In the past, we said there was 100% risk of suicide among the people we called transsexual in those days. I don't think anyone thinks that today, but there is a real risk of suicide. And
okay, so she actually just points out a significant admission there. One of the stories that you'll hear again and again from parents here in stateside when you listen to the hearings is that the parents take their kid to a gender clinic and the parents have questions. They're not really on board with everything. The parents have known this child since they were born. And in many cases, particularly the ROGD type patients, the rapid onset gender dysphoria, the parents have their memory, their experience with their child from infanthood to adolescence. And they'll say, my child never had an issue being a girl. She celebrated being a girl when she was young. And then when she was a teenager, she got access to social media. And then we started to see this change. And now they've come out as trans. Even though my child is now telling me that they've always had problems with being a girl, it just doesn't, there was no, we were accepting family. If they had problems with being a girl, we wouldn't have criticized them for that. But that is, when you listen to the transitioners, they'll say that there are influencers in social media who will tell you this is the story that you need to say in order to gain access to hormones. And so you know what you need to tell the clinician there. But the response that the parents will give is that we'll get from these clinicians when the parents have questions is, your child is going to kill themselves if we don't immediately affirm this. The risk of suicide is so high. And the fact that she says we used to tell people there was 100% risk of suicide kind of tells you that those stories are likely true because that is the background they're coming from. Thankfully, she's now saying we no longer think that that's the case. So they've backed down a little bit. But as you'll see in this episode, they're still using this looming threat of suicide to say we've got to do all of these interventions. Otherwise, your child will kill themselves. And there's a couple of other observations about that dynamic that need to be made. But ultimately, what it is a coercive way to obtain consent from parents. And you think about it, like, what other thing is there where you use the threat that if we don't do this, then your child is going to kill themselves? Joanna in the comments brings up another point with where if it is the case that we're just seeing the tip of the iceberg and that people who were privately struggling with dysphoria are now hitting the clinics and the suicide rate is that high if you don't treat dysphoria, then there should be a flood of suicides that could be accounted for this in the past, but that is not the case. And the other thing is, if you look at the difference between suicidal ideation, having thoughts about suicide, it's a different group of patients, a different rate than actually having a suicide attempt or having completed suicide or a suicide completion. And those numbers tend to get thrown around and mistaken one for the other. So while you may have patients that report, yeah, I've thought about suicide when they answer a survey, well, then the number of patients who answer that in a survey where there may be incentives to answer a survey in a particular way then gets transformed into a statistic. And then that statistic makes its way into legislation or into the justification for legislation. But rather than suicidal thoughts, they'll say completed suicides. And there's some suspicion that that's what led to elevated reporting of suicide statistics in trans adolescents in Sweden that is explored in this documentary. Okay, so let's keep going.
And other mental health problems.
Okay, so the big takeaway from there is that even the head of the adolescent clinic, the child and adolescent clinic, who people are looking to for answers to say, you know, we've got to identify the right patient population in order to take them down that medical and surgical therapy pathway. They don't understand the full dynamics of the patient population that they are treating. And what happens is when people try to understand those population, specifically Lisa Littman publishing on the population and coining the term rapid onset gender dysphoria, that activists use the power of social media to try to vilify and use claims of hatred and bigotry to shut that research down and to minimize its impact. Okay. So what do we have next? Just a reminder, if you want to share any of your thoughts with the audience here, that you can call 210-422-2222 and share your perspectives. If we don't get any calls, we'll just keep going with our commentary here. If we look at our next slide.
The KID team in Stockholm.
That's the same one. Okay, so next is the length of the assessment. So the question of how long does it take to determine once the clinic is presented with a patient. The patient, again, this assessment now is after the waiting period. So in the case of Johanna, the waiting period was around 18 months. Once they hit the clinic, now the assessment time begins. And what the assessment should be is to explore all the different facets of an individual's psychological profile, of their family and social dynamics, and make sure that this patient meets some form of criteria that would allow us to implement this therapy with some confidence that it's going to have a beneficial effect in their life that outweighs all of the costs and all of the risk factors. And the way that the medical profession should be working is that there are a body of studies that show that for a patient population that meets certain criteria, we implement this therapy, and we've now have evidence to show that it is going to work out to their benefit. We're using the Dutch protocol and the Dutch studies to implement these procedures, but what we should be doing is applying, if not the same, then very, very analogous standards for selection of patients in order to send them down that pathway. And what we're seeing in clinics, both in Europe as well as here in America, is that they're not using the same criteria to select those patients. So what is this assessment doing then? And how long does this assessment take? Can you get to know a patient well enough to determine that they would be a good candidate for this therapy if you only meet with them for a few sessions that are half an hour to an hour each, when it takes much longer for particularly a child to be able to understand the gravity of the irreversible changes that accompany these surgical and hormonal treatments? That's a source of controversy. So this documentary explores with the head of the KID team, how long does it actually take? How in depth are you going with these kids as they present to you? We saw with the story of Johanna that she had a complex background that involved anorexia, it involved body dysmorphia and self-harm, and those are complex issues that it should and would take a long time to really delve into and determine if the identification of being trans is going to be the solution and is going to be the pathway to healing. Let's see what they had to say. Okay, so if we come back to here.
The assessment is a vital step. It determines whether the person is to be diagnosed and begin treatment. We have several psychologists and child psychiatrists and a secure method. We follow international guidelines. Thanks to parents who let us read their children's records, we saw that assessments can be very fast. In one case, it took 5 weeks from the initial visit until doctors decided to prescribe puberty blockers. Here at KID, how long does the assessment process take? From the initial meeting until a preliminary diagnosis is made. That depends on how simple or complex the case is. In the majority of cases, it takes 3 to 6 months. We've seen that it can take 5 weeks from the initial meeting to the preliminary diagnosis. I'd guess that those cases are younger children, where it isn't as difficult to make a preliminary diagnosis. Children that have clearly been the other sex since age 2 or 3. And in those cases, it can go faster. In the cases we've seen, it was gender dysphoria that arose in the teens.
So I just want to go over that particular point she just made. She's saying that if a child presents younger and they have the story of having identified or had gender dysphoria since they were a young child, then actually they are fast-tracked. The assessment is actually a lot quicker, and they call that a simpler case. And if you put that in contrast to the history of the watchful waiting paradigm, it's those patients that if you do conversational therapy and support without the social or medical transition as they go through the process of childhood and adolescence, that something on the order of between 60 to 90%, depending on which study you look at, eventually desist. And a significant number of them may end up being gay. But that process without irreversible hormones and surgery would lead to a majority of those patients in the population that she just said is fast-tracked, eventually having the dysphoria resolve and being then able to go on and live their life without dysphoria being the predominant psychological feature of whatever issues that they have. So she's already given us a snapshot into how this change of paradigm between watchful waiting and immediate affirmation using the Dutch protocol could affect somebody's life. And that's an important point that I want to make sure is not lost on this. And let's reverse it and go back a little bit more.
In the cases we've seen, it was gender dysphoria that arose in the teens. One was 16, one was 15. One assessment was 5 weeks, one was just under 2 months, and about 5 consultations. That sounds very short for such a decision. It's hard to say why that is, but I guess they were cases that were very clear. But 5 weeks to a preliminary diagnosis? Is that still a careful assessment with a large number of visits? That depends on how many visits they squeezed in. You say 5 in 5 weeks? That sounds ambitious, squeezing in so many visits in such a short time. You don't think it sounds short? No, because it all depends. It could be a person who is very easy to assess. And if they managed 5 visits in 5 weeks, they've managed a lot. You know each other and haven't lost touch between visits. So 5 weeks can be enough. Yes.
That, she makes the point there that there can be people who are really easy to assess. At the same time, in the same interview, she's said that we don't understand why we have such a flood of this new patient cohort. And remember, the new patient cohort are young women who have, in a majority of cases, many other complex psychological comorbidities. The disconnect there, I think, between, because if you ask them, well, what do you design your protocols on? They're going to be able to point to WPATH and the standards that they set. And so they'll have the veneer of defensibility of what they do, but then what actually happens in practice can be a very different story. And this is something that comes up when you listen to the hearings and have witnesses testify. You'll have a senator ask someone who's come to be critical of this affirmation-only model. They'll say, well, when you ask the clinics, they say they're following international guidelines. And the response is, well, we know what they say, but when you actually talk to patients and you listen to the stories of the parents, they'll tell you that they've made an exception, or for some reason their kid got puberty blockers or got hormones after just a very, very minimal number of meetings or sessions. And in the case of this documentary filmmaker, the only reason they were able to push back on her narrative is because they got a hold of the medical records of parents who had issues with how the clinic was treating their kids. So they were able to present these exceptions. There's another instance in the interview with the head of KID team where they point out a contradiction between what the team says and what their practice is. And it's on the point of whether or not they would advocate for surgical intervention or medical intervention in a minor without guardian consent. And on their website, it says, we refuse to see patients without guardian consent. And they press them on this issue because it is the case that if somebody reports a parent and social services will support the kid in their trans identity if a parent refuses. And so the clinic will then intervene and start therapy on a kid without guardian consent, as long as they can point to social services and have the defensibility of social services have said that they can do that. And it's complicated, but it's an exception. And so those exceptions, once they get out, will tend to attract people who want to use those exceptions. And that is where the type of legislation that is being considered here in the States, or the type of reversal of policies that's being considered or implemented in these European countries, are trying to bring up safe rails to prevent exceptions like that happening. Because what the clinics say is the standard, they may not go into, yeah, that's the standard, but we'll have rare exceptions. But just how rare or common those exceptions are is never documented, and they don't produce statistics to say how many of the patients have they turned away and so forth. So let's keep going. If you want to join the conversation, you can call in at 210-422-2222. Kyle Gray makes the point that if patients can make it through the couple of months and then desist without doing anything that will cause long-term consequences, they're going to be so much better off. This is a big point of contention, because when you drill down to it and you talk to particularly activists, there's an idea that they don't want to see desistance as a positive thing, because since there should be no difference in accepting a trans identity versus what they consider a cis identity, and society should be accepting of both of those identities, we shouldn't consider one outcome any better or worse than the other. And so you shouldn't consider desistance to be a better outcome. And so an argument like that wouldn't actually hold any water for them. But when you look at the complications, the risk factors, suicide rates, other comorbid psychological factors, it's clear that patients who continue to exist in experiencing gender dysphoria have a much harder pathway ahead of them. And so if there is something like watchful waiting that causes that, or that allows that gender dysphoria to resolve, then that process should be given its due, because then they're able to live the rest of their life, certainly with other issues that will come up in the course of any other life, but gender dysphoria will not be the thing that is the focus of their primary psychological issues. Okay. Let's see. If you want to join the conversation, you can call 210-422-2222. Let's see what our next issue.
The assessment is a vital step.
Okay, so we've got a call. Let's take a look and see what we can find. Hello, you're on Talk on Things and Stuff.
Yeah, hi, Jonathan. Can you hear me okay?
I can hear you fine. What's on your mind?
Okay, because I live in Ohio, and I know you had mentioned that you are going to feature the Ohio hearings. I think those are the ones that were last year, correct?
I believe so.
Okay. This is a subject I've been studying a lot lately. I was actually vice president of our local PFLAG board for 5 years, and so have been pretty active as far as supporting our LGBTQ community and our kids especially.
Can you repeat that organization name and unpack it a little bit?
PFLAG.
Okay.
Yeah.
What is?
I thought you might be familiar with it. PFLAG, P and then flag. It's a national organization with local organizations throughout the country, where it originally stood for Parents and Family of Lesbian and Gays. And then it has a broader umbrella now for the entire community, of course. So I became involved in that when 2 of my 4 kids identified in the community. And but lately, one of my daughters who's in the community has been doing a lot of research, like on this whole issue of transgenderism. And I've been reading stuff on it, and it's kind of caused me to take a slight turn here, or a significant turn, I should say. And I find how you cover these topics really, really educational and engaging. It's really difficult when you've been in the support community, because everybody automatically calls you hateful, et cetera, if they think you're not on board 100%, which I know is one of the points that you've brought out. I'm just concerned about some of these kids being fast-tracked through this. Although I think here in where I live in Columbus, we have some really exceptional care where I don't believe that kids are being fast-tracked. I think that through the nationwide children's hospital system, they take their time in assessing not just the kid, but the entire family. They talk to the entire family and see what other issues are going on there, which I think would be a much more valid approach. So it would be nice to see. Yeah, go ahead.
No, it's very clear when you watch those Ohio hearings, because you get people from various different support organizations, both for and against this. And generally, parents weigh heavily in this, because it's the parents who are heavily invested in the welfare of their kids. And like you, even if they have been traditionally, on the left, Democrat voting, supporting the LGBTQIA community, once it starts to affect their lives personally, and they see how things aren't as simple and black and white as maybe they thought that they were before, and they just want to say, okay, I totally support the community, but let's just slow down a little bit and make sure that this is, something that we're being thoughtful about. Well, just that cautious approach is then vilified as, well, you're not all in, you're a hateful bigot. And so it can make things very difficult. And some people feel like they just have to back away from that at all because they don't want to ruin their reputation. They don't want to be seen as hateful and bigoted. And then you take that really kind of high stakes social environment, and then the high stakes social environment of the politics involved in this. Because when you watch in Ohio, it's really clearly split. It becomes very clear who the people are that are for the transition and against the transition, and they tend to fall along political lines. And there are a few points where they end up having to shut down the hearings because there's some political infighting that goes on there. So it's just a really high stakes environment on both sides. And I can imagine as a parent and as an activist, it's really hard to navigate. And then in the middle of all this, you have medical professionals, and you have medical professionals who are supporting this, and those that are critical of it. And I agree with you. It becomes very clear as you listen to the professionals who are involved in this care that, I don't know, I'm a physician, so I tend to try to see things from their perspective. They are trying to help patients, and they want to do what's best. And they have the kind of the blanket of being able to point to professional societies and say, these professional societies have endorsed these guidelines, which set these protocols that we are treating these kids with. And so it's a form of deferred accountability. They can say that I don't have to look at the studies. I don't have to make sure the studies are endorsed because I can just point to the society. And then they'll frequently say, for example, the Pediatric Society endorses this, or the Endocrine Society, and that society has tens of thousands of members. And so it gives the idea that there's tens of thousands of doctors who endorse this. And what the critics will say is that, well, you have to, when you look at those guidelines that were put out by that society, in the case of, I think it's the Psychiatric Society, it's like one person that wrote the guidelines, and then it was voted on by a small body of people. And even though they'll say 10,000 members are a member of this professional society, that doesn't mean that all 10,000 of them agree with those guidelines. And so it's a really complex landscape to navigate. And, just as a parent, as somebody involved in those support communities, how do you act? What do you do? How have you managed to tread through those waters?
It's been very difficult. That's one of the reasons I stepped off of the board in December, because I really feel like I can't say anything to any of these other parents, right? I'm in a group of mama bears, and we everybody is completely rah and calling anybody who says the least thing against what's happening as bigoted and hateful, even if that person just wants to go with the science, right? Because everybody says go with the science, but I'm seeing that people don't necessarily do that when they have their mindset.
And as we've seen in this documentary, and we'll explore in the future, the science is not clearly set, and you can't simply say go with the science and assume that you know what that means, particularly when what we perceive as the science sometimes is just, a study will be done. Some journalist that may have an ideological bent will post a news article with a headline that says this study proves X, Y, and Z. And then that will get reposted and then linked in an argument, and it'll just make its way across the internet, where if you actually go through and look at the study itself, it may not have the strongest evidence. It may have only looked at a very narrow subset of patients, and it may have only done a very small amount of follow-up to see if the effects actually have it. And so you can't really say that the science is settled on that question. And the mixture of ideology, politics, and science is really complicated, and you can't simply say trust the science and know exactly what you're talking about.
Right. And some of the articles that have been shared with me aren't scientific at all. There's no footnoting of any studies, et cetera. And I've, brought that up, but I never hear any feedback on that point.
Well, that's a common, this channel started out exploring histories and controversies of the Mormon religion, and the experience of being able to bring up some controversial point from history, which would tend to undermine some very dearly held beliefs. And when you bring those points up that are kind of factual and incontrovertible, then kind of just having no response is very familiar. There's, these things that are really important to you, whether it's a mama bear who is dealing with a child who has dysphoria and you love and support your child. You saw how hate and bigotry affected the gay and lesbian people in decades past, and you don't want to see that repeated in your own life, and you want to be somebody who is supporting. It can feel like the only thing that you can do is support and be a cheerleader for this issue of gender dysphoria in the same paradigm as how you would support a gay or lesbian child. It can feel like it should be the same, but as we're seeing, particularly with the experience of detransitioners, it's not the same.
Yeah. And I'm glad you brought this all up. That's exactly how I know your channel, is because I also left the church in 2018. And this issue was actually my gateway out of it. And then I did a lot of the research and truth claims, et cetera, et cetera. But because I have been in a cult-like environment, I guess I can recognize those signs in something like this, or even politically. And I see these, cultish behaviors all over the place.
Yeah. And it's one of those things where you start to realize when you escape a high demand religion, you assume, oh, it's because there's claims of divine authority and all of this religious spirituality. That's what makes up a cult. But then you encounter political or secular groups that have that same dynamic happen. You realize, well, maybe it has to do more with human psychology and vulnerabilities that we all have to being accepted within a group, to believing that we're good people, and to having ideas shape our notion of who we are and what the world is. And those forces exist independent of any claim of divine power or authority. And so you need to be on guard for issues of groupthink and social forces like that, regardless of whether you're in a religious context. And I think that's where, for me, understanding those psychological forces has been very important. And as you say, it kind of allows you to be more sensitive to those red flags when they come up. And I certainly, as I started to explore this and started to listen to detransitioners, saw a lot of those red flags come up. And there's a series that I did in interview with a detransitioner that's part of the Is It Culty series, that if anyone who's listening, if anyone who's listening hasn't seen, you can go through. It's a very extensive interview looking at the same psychological forces and groupthink dynamics that you'll find in a cult religious context, and then seeing how they affected the life of a detransitioner as they went through the trans rights activism community. And there are a lot of very concerning parallels that I think it's important to be aware of.
Yeah, for sure. I really appreciate all your programs that you do. So thank you so much.
Oh, well, I appreciate it.
Take a long time.
Well, it's those things that become very personal that you want to explore, that I kind of wanted to approach this the same way I approach the church, where you want to really try to understand all the different ways. And particularly if there's a side that says, don't listen to those critics, don't listen to the other side, then, when I was in the church, they said, don't listen to the critics, don't listen to the other side. But it was kind of like, you need to go to those people and listen to them. Not because you're going to immediately accept what they have to say, but at least see what the counter arguments are, and then dig deeper, see if those arguments have any merit. And that's where I think that's where you feel like you have a good understanding. You should be able to articulate the best arguments of the opposing side to show that you kind of understand that. And while you explore that, don't be afraid to let those things alter your perceptions in terms of your understanding of something, because I think the quest to get more information and better understanding should not be closed off by the possibility that you may not know everything to start with. And so learning and trying to figure that out is an important process on it. So where do you go from here? Because I got the sense, and as we will see in the Ohio hearings, I think they ended up passing the SAFE Act, but there are some legal challenges to it now. Is that your understanding as well, or?
I don't believe it was passed.
Oh, okay. So I know it had come up in years past and had failed. And so every year they seem to try to do it, to tweak it. And this seemed to be the year. There was more inertia in trying to get it passed. And we've seen other states do it.
Yeah, we have an even more conservative state house for 2023 and 24. Yeah. So I do expect it to come up again. But for example, something was, I went to one of the hearings that was against this, right? Mm-hmm. And something was referenced about something that was said in the other side's hearing. And I said, oh, I didn't listen to those hearings. And a fellow mama said, oh, you don't want to go and listen to any of that horrible, hateful stuff. And that's kind of the exact opposite of how I feel. I'm with you. I'm like, well, I want to hear what is being said. You know, what is horrible and hateful about what they're saying? Mm-hmm. And is there any valid information on their side?
Yeah. Yeah. And particularly when you hear those labels applied to the other side, whether it's hateful, whether it's ignorant or bigoted, or whether it's brainwashed or indoctrinated on the other side, I think it's helpful to let those labels fall and don't try to examine. Like when I listen to, for example, either an activist or a gender clinical psychologist or endocrinologist who is involved in this therapy that is doing something that, after my review of the evidence, I don't think is the right medical or ethical pathway, I don't see them as brainwashed or ignorant, or at least if that impulse comes into me, I try to fight it off and just put yourself in their shoes. And I think you can do this with everyone on all sides, as they're trying to do the best with what they think is the best. And it's possible to go through this without really seeing anyone as a villain. There's a bunch of people who are trying to do with the information that they have the best for the people involved. And some of it is just gaps in information. I think particularly on the medical side, you'll hear several statements from clinicians saying there's lots of evidence. The science is settled. There's lots of evidence on this is the right thing to do. But if you go in and question deeper about what they're citing for it, you can see that there are assumptions, there are incorrect assumptions being made about the conclusions of the study, about the strength of the study, about how the guidelines were implemented by the various professional societies. And when you dig deeper and you see that those professional societies are calling things recommended and then qualifying them by saying that the evidence is very, very poor, well, once a clinician gets confronted with that information, they hopefully would be open enough to recalibrate their response and say, well, maybe the evidence that we have for doing this is not as strong as I previously thought. And that should give me some perspective to reevaluate what we're doing here. And that's another part of this documentary that was so great, because they show a doctor confronted with that information who changes her mind, and then she resigns because she doesn't have the option of not going forward with implementing these therapies. And we'll see that segment here shortly.
Right. And where do I go from here, you had asked?
Yeah.
I have to, I continue to learn and, read things and listen to things. But I have to really keep my mouth shut, because I don't want to be seen as, oh, did you change your mind?
Yeah.
Or
no, it's the same. Yeah. It's kind of the same thing detransitioners have, where it's like, wait a second, you change your mind. Well, now we can't trust you. Now you're an unreliable person, and it's embarrassing and shameful. Now, if you have family members who maybe haven't been exposed to or haven't seen the complexities involved here, such that you're not 100% in for all of it, even if you are supportive of your LGBTQ family members, how do you navigate those family dynamics? Because I've seen and heard from many people that if they say, hold on a second, it's not as simple as you are claiming, to, for example, a teenager who is identifying as trans, and wants these surgeries, that they then get vilified and it alienates them from their child. Do you see that as a force affecting some people, causing parents to hold their lips shut?
I'm not sure that I've actually witnessed that offhand. The mothers that I have dealt with are all extremely supportive, to the point where they definitely don't hesitate to criticize a parent who wants to put those brakes on. You know, they accuse them of not loving their child, which is completely false. But my two kids who are in the community don't have gender dysphoria issues, so I haven't personally had to deal with that. But I do know a lot of moms with kids who are either transgender or are identify as non-binary. And I guess we always hear the mantra of gender is on a spectrum, right? It's not binary. It's all fluid. And, you know, so that is the main teaching of this group. But
well, it's funny that you bring that up, because the question of whether you're a good parent or not in your support of a trans child makes its way into those hearings that are where they bring families and experts to testify about needing safeguards. There's one parent in particular that comes and shares the story of their child who is trans, and they use the birth pronouns of the child. And one of the senators, or one of the representatives who's questioning this witness who came to say we need to be careful about proceeding along these therapeutic routes, starts criticizing the mom for using the wrong pronouns for their trans child. And it ultimately leads to some controversy, because they have to keep reminding the representative that the witnesses that come here are guests, and we shouldn't be attacking them or criticizing them or calling them hateful, bigoted parents, because they have their own lived experience as parents, and they have a right as parents to frame their story as parents with their child, how they choose to do that. It's a challenging moment in those hearings, and we'll get to that eventually.
Yes. When are those going to air?
Well, I have another parent from Ohio who is going to help work through those with me. There's several different episodes. I already have them all broken up and ready to go. So hopefully over the next several weeks, we're just going to kind of take one witness at a time for those initial hearings. And then they kind of lump everyone together on the follow-up hearings for all of the 5-minute against testimonies. But it's really in those first hearings where you get the representatives able to challenge people on both sides of the issue, where some of the more meatier discussion happens. So hopefully in the next couple of weeks, by a month from now, I hope to have them done.
Awesome. I look forward to seeing them.
All right. Well, thank you so much for the call.
Yes. Thank you so much for all you do.
All right.
Bye-bye.
Take care. Bye. Okay. So if you would like to join in the discussion, you can dial 210-422-2222. And in the meantime, let's see what our next slide is. Okay, so we talked about the length of assessment. Next, we're going to take a look at the question of puberty blockers and risks. Now, just to frame this correctly, what will generally happen is a child will express gender dysphoria. They'll be taken to a gender clinic. And because of that dysphoria, there's a protocol that will start puberty blockers at first so that they don't start undergoing those changes of secondary sex characteristics. And then after a period of time, usually when they get to the age of 16, if the child still is experiencing gender dysphoria and chooses to do it, they'll start cross-sex hormones and then subsequently undergo surgery. But it's this whole puberty blocker thing that happens. And the advent of puberty blockers started once a certain type of gonadotropic releasing antagonist hormone was discovered, and we learned we could stop the process of puberty. Then clinical researchers used it for a number of clinical indications. And then when they started listening to the story of older transgender individuals, they were called transsexual at the time, expressed that they wished they hadn't gone through puberty, because then they had to deal with the challenges of all the changes that puberty brought on. There was a light bulb that went off in some researchers' head, and they said, what if we could use this hormone that we know blocks puberty that we've been using for other reasons and apply it to these children who have otherwise healthy bodies but are experiencing gender dysphoria, maybe it will help them. And so there are people who have criticized that type of justification for starting the therapy, but whatever can be said about it, here we are, and we have this tool set that has been used, and there's a body of evidence for it, so we're dealing with it now. And so understanding that whole process is important because it's marketed as a pause button. But the thing is, puberty is the time where your body is undergoing changes that extend far beyond simple testicular or penile enlargement or hair growth. It's also involved in the maturation of your brain and your bones and other aspects of your body that when you put a pause, you're not simply pausing hair growth and voice deepening, you're pausing all of these other effects. And the thing is, your body is a complex system. It is not simply the hormones that are blocked by these puberty blockers that undergo a dynamic change during adolescence. There's also growth hormones, and there's other factors in human development that are happening at the same time as estrogen and testosterone. And so there's a window where all of these things are supposed to work together in a grand orchestra to be involved in the human development from a child into an adult. And by simply pausing testosterone or estrogen, you're missing a window where those changes happen. And that's where researchers are finding that something like bone growth and bone density is supposed to happen during that puberty change. And if you pause puberty there, you'll stop that bone density from happening. And if you later take away the puberty blockers, there's no guarantee that you're going to continue to get the same bone mass that you have. And that can lead to premature osteoporosis and can lead to shorter stature and all these other changes that add complexity to the ethical consideration of whether this intervention should be justified, particularly, and anytime you hear any of these risk factors, you should keep in mind, particularly when we know from our past history of watchful waiting that if you do supportive psychotherapy instead of these hormonal and surgical interventions, that a huge percentage of patients with that gender dysphoria will resolve anyway without these irreversible changes. So that is when you do a cost-benefit analysis, you have to take that into consideration. And it seems to be that that is not being taken into consideration. So let's go back with these puberty blockers and see what our next video segment holds for us.
Gender dysphoria is a struggle. Many are in a hurry to get help. The first medical step for teens is often puberty blockers. They temporarily stop puberty, so the body doesn't continue developing into a woman or a man. The aim is to help the young person to feel better. Anna Olivikrona is an endocrinologist and chair of the Swedish Pediatric Society's endocrinology section. When puberty starts in boys and girls, it starts in the brain, which sends signals to the ovaries and testicles to start producing sex hormones. These hormones are then sent to various target organs and lead to the various things that happen during puberty. When I think of a young body that is meant to have tons of hormones and 1,000 things happening, that's how we're programmed. If we shut down that system, what consequences might that have? Actually, that isn't fully investigated. We don't fully know what happens. We know that the bones don't mineralize. You stop growing in height, and you stop the processes that would normally occur. The long-term effects haven't been studied enough, so we don't know.
Now, if the research has no scientifically valid basis and these harms are known, and there are so many unknowns related to fertility and reproductive potential, and they know that bone density is an ongoing issue, how is it possible that there is not a national inquiry into the referral of children for services like puberty blockers and cross-sex hormones?
This was the outcomes only after 1 year. And after 1 year on puberty blockers, there were a lot of things that the children got worse in several respects. So the most disturbing aspect of that was that the children reported a higher level of self-harm. And that, to me, raises a very big red flag.
All right. That last point was made by a researcher, Michael Biggs. And if you've been watching this channel, he'll seem familiar to you because he was one of the expert witnesses that testified before the Florida Medical Board. And his name became known in the discourse over this issue because he kind of independently looked at the studies that were being used to justify these therapies. And he saw that the evidence was not as strong as they were being marketed as, that the study design was not as foundational as you would expect something to result in the level of recommendations that we're seeing here, and that the assumptions about the outcomes for these children there were some gaps about data that they were not actually exposing. One of the things that in particular he was involved in is that follow-up studies that were trying to reproduce what the Dutch protocol had originally set had been announced, but there were no results. They had said, well, we're following and studying these patients, but then no subsequent publications for those patient groups that had undergone this therapy were coming forth. And he was concerned that it may be because the data was not good. It was not positive. And other people that have published have seen if you don't publish something that is positive and affirmative towards these medical and surgical interventions, then you're either not going to get published, it'll be turned down because it's too politically charged, or your institution won't want you to publish because it'll be a magnet for bad press or target of trans rights activists for the institution. And he pushed for them to publish their results, and eventually those results got published, and they indeed reflected that the results were not as promising or positive as people had hoped that they would be, because the question of this Dutch study had been done, and it's done in one institution. There are no randomized controlled populations to compare it with, and so it's not really the best study design. If you can't improve the study design, can we at least reproduce that at other institutions implementing a similar protocol to see if it stands up to reproducibility? And that has not really been done yet. So we're affecting the treatment of people worldwide for something that the foundation of it is quite shaky. So definitely check out that testimony by Michael Biggs. It's really good stuff. And he's got another presentation that I hope to be able to add to the channel soon, because what he presents as somebody, his specialty as a sociologist is looking at data and looking at the ways that you profile different populations and explain the data. And he does a really phenomenal job of that. Okay, so let's take a look now at our next slide. If you would like to join the conversation and share some of your thoughts, you can call in at 210-422-2222.
Gender dysphoria is a struggle.
Okay, let's see here.
Many are in...
It's the same one. There we go. Okay, so we talked about puberty blockers and the fact that there are a lot of unknown effects, and yet we are applying them to patients that, again, I have to reiterate, if we compare what those effects are, whether it's premature osteoporosis, lower IQ, other side effects, compare that with watchful waiting and exploratory conversational psychotherapy, then we already know that we have a way to resolve gender dysphoria, or to allow gender dysphoria to resolve on its own without these irreversible effects. That should be the comparison that is made, but that's not what's driving these decisions. So now let's look at the next group of interventions, which is cross-sex hormones and the possibility of unknown long-term effects.
Trans women receive the female hormone estrogen, and trans men receive testosterone. Medication with cross-sex hormones is lifelong. It's a powerful treatment that affects the whole body. There's no definitive knowledge, but several studies link testosterone to cancer and increased risk of heart attack. We talked about the risks of treatment and the lack of research in our last report last spring, and several government agencies confirmed this. What do you say to the regretters who see your recommendations? The National Board of Health said this, but I wasn't mature enough to decide. The recommendations we've developed are based on the best knowledge that was available at the time. It isn't complete. We can't find a highest level of evidence for treatment. For example, we can't do randomly selected treatment or placebo treatment. The doctors who do this say that all this is thoroughly investigated. Is that not true? And other doctors say it isn't. Both groups refer to different types of facts. We want a compilation in a systematic overview with a quality assessment of the facts. Hasn't that been done? No. In several parts of the world, research into transgender health is ongoing. An American team studied a large population. While the treatment boosts quality of life, the results for trans women are striking. 6 years after beginning estrogen, a greatly increased risk for blood clots and serious kinds of stroke arise. This is really interesting. Does this mean that even those of us who are okay, you're up here, the study ends after 10 years? How many years have, well, since I was 18, so almost 20 years. That's a sharp rise. But you didn't get information? No information about the risk? No, this is the first time I'm seeing this, so. I thought the graphs were striking because here it's primarily curves D and E, number of years after the first estrogen intake. I think they really shoot up. They really do. I haven't had time to look into how many there are and what the sources of error are, so I feel that you have to understand what the potential sources of error are. There may be an explanation. We hand over the report, published last summer, to Anna Oliver-Krona. It is the biggest study to date in the United States on transgender people. I absolutely think the results of this study are worrying in terms of the increased risk of thrombosis with estrogen treatment. Worrying in what way? It's a significant increase in risk after a relatively short treatment period. One of the known risks of estrogen treatment is a greater risk of blood clots. This is what worries us. This clearly shows a significant increase in risk. What does that mean for the treatment? We pediatric endocrinologists are and want to be cautious in treating young, growing people. It's very important to have detailed information before initiating treatment, to carefully weigh the positive effects against known and unknown risks.
All right, so we've had a stream flag and it'll drop out, but we'll continue here. This brings up, because what they're exploring are previously unknown side effects of an intervention. And at one point, they're interviewing a blonde-haired woman who is a trans woman who's one of the most popular celebrities in the trans community in Sweden. And her story is covered in the second episode of the documentary as well. because she published a book that was her narrative, and her story becomes even more important when we get to the next episode, because after being exposed to this data about the risks, she later says that if she had known about these risks and had the chance to choose again, she would not have undergone the various therapies that she did, and she would have worked through living as a gay man, which is what she identified as prior to transition. Now, the issue of informed consent becomes very important, because as a medical professional presenting a patient with a course of therapy, in order for that patient to give informed consent, which then justifies ethically continuing with the intervention, you have to be able to give them a profile of the risks that are involved with the therapy, so that the patient, in conversation with their doctor, can weigh those risks and benefits and make the right decision for that individual patient going forward. And certainly there may be people who look at these risks and say they're willing to take those risks, but it should be part of the process. And you can only do the best you can with the information that you have at any given moment. But there are 2 and now 3 papers in particular that are very important on this question of informed consent for children posed with the possibility of this type of intervention. And Dr. Julia Mason is, if I get that name correctly, is a pediatrician who's been involved in the public discourse over the issue of healthcare for children with gender dysphoria, who, working in conjunction with Stephen Levine and others, has published a number of papers, and I'm hoping to get her on to talk about the complex issue of informed consent as it applies to children with this proposed type of therapy, because there are a lot of factors that don't generally get included in the discussion of just how the medical profession initiates these therapies. And in particular, when you acknowledge the fact that informed consent has to inform parents and patients of not only the positive potential benefits of these therapies, but also the risks, the negative outcomes, as well as the effect of alternative forms of therapy. And when we say alternative, you have to go back to what watchful waiting has a good expectation of producing. Because as that person said, that we can't do randomized controlled studies, we can't do placebo studies. All of that is true. But what you can do is you can compare the outcomes of these interventions with what would be considered kind of the course of this disease process, this discomforting process in the lives of these people, with that watchful waiting paradigm, where, again, we see a majority of children who have that gender dysphoria desist with the conversational therapy and supportive measures. Okay. So hopefully our stream is back soon. We will move on to our next slide, if we can get them here.
Trans women receive the female.
All right, next is questionable facts about suicide. All right, so this is dealing with the fact that in Sweden at this time, there's this bill trying to be implemented into law, which would allow children as young as 15 years old to get sex reassignment surgery without guardian or parental consent. And the justification that they're using for that is that there is a tremendously high rate of actual suicide attempts among kids who are waiting to get into their clinic. And so we've got to remove any safeguards to be able to give these kids a chance to have the will to live. And so that claim is being repeated over and over again in the political maneuvering to try to get this bill passed into law. The journalists here said, let's dig into that claim. Where does it come from? Where do the numbers come from? How substantial is it? And that's where this documentary ended up kind of blowing the lid on some stuff. So let's take a look.
Treatment is questioned, the suicide risk is brought up. A 2014 government inquiry found that young trans people take their lives while waiting for surgery. The inquiry proposed lowering the minimum age. Last year, the government presented a bill to permit, from the age of 15, the right to gender-affirming surgery without a guardian's approval. The Swedish Federation for LGBT Rights has worked hard to get this bill written. Trans people as a group have poorer mental health than the general public. There are many suicide attempts. We have plenty of figures on that. And if there are cases when it is judged likely that a person will be helped to have a good life through gender-affirming care, then they should be entitled to it without being hampered by the law. This is an extremely important issue, getting this legislation in place. There are transgender people who try to take their lives. One study shows that 40% of young trans people have tried. Those are terrifying numbers. This can be a matter of life and death.
That number, 40%, becomes really important because it's not saying 40% of people have thought about suicide. It's saying 40% of people have attempted suicide. And it's that kind of buzzworthy headline that gets then used as a justification for the bill to try to persuade people to vote for and support the bill. But is it real? Is it true? Where does that number come from is kind of the question that they're addressing here. I'm trying to pause periodically so that the stream does not get disrupted for copyright, which it seems to have been already. So some people watching live may not be able to see it.
How many take their own lives while waiting to get to you? We have a very long queue. It's 18 months. And we don't go looking for people who disappear from patient records. But we would find out if somebody had died by suicide, if that person didn't appear, or from the referring psychiatric ward. So I've never heard of anyone who died while waiting to get here. The bill refers to the 2014 inquiry, which states in 5 places that young transgender people take their own lives while waiting for surgery, but there is no source given.
So this becomes a major question because that threat of suicide is kind of the most powerful punch to try to get people to override any other concerns they have. It's kind of like when you look at different chemotherapeutic agents. Many of the chemotherapies are devastating to the body, but we consider giving them to patients because it's either that or death by cancer. And that's a very real, tangible outcome. And so that then justifies us implementing those therapies that otherwise we would never give to a normal, healthy body. So if you make the decision between these interventions and death by suicide, then it can seem to make sense. But if that number about the threat of suicide is artificially inflated, or if it's fabricated out of nothing, then you are manipulating the data points that go into a legislative body making a decision for how these therapies get allowed in the country. And that's an important thing because facts do matter in this regard.
Where does this data come from, and is it true? We talked to doctors and organizations that participated in the inquiry. Anders Rydelius built up Sweden's treatment for gender dysphoric youths. I'm not personally aware of any such cases. But you know that the inquiry also included special interest organizations, and that may be where the information came from. Those organizations. I'd say it's more likely that some would have taken their own lives if they hadn't received gender-affirming treatment. Whether this was specifically linked to sex reassignment surgery isn't something I can answer. Do you remember where the data came from, the LGBT Federation? I really don't know. It might have come from them. The Federation.
So they're exploring this because this report that says in 5 different places that people died while waiting for surgery or waiting to get through the system took inputs from government agencies, from clinics, from interested parties, which are generally activist groups that are involved in trying to promote the rights and access of the people for which these therapies would be targeted. And they're trying to find where this data point came from. And everybody's like, well, I don't really know. They got the government agency and the clinics to say it's probably these activist groups that have. And so when input from all these various different forces comes in an inquiry, they may not be applying the same scientific rigor, saying that you have to be able to have evidence to back up any of your claims. They're simply putting out the response that they received to questions from various factors. And this isn't to say that anybody lied. It may just be that somebody overstated or was overly confident about a particular data point, or felt very strongly about something and made assumptions that, kind of like the telephone game, eventually made their way into the report. So that's where an investigative journalist that's willing to dig and say, where did this actually come from, is a really powerful thing. And that's why we're so blessed to have this Swedish Mission investigative journalist, because very few places elsewhere in the world, especially in the English-speaking world, have braved these waters, because it is so risky. And they even got called hateful and bigoted, as they mentioned in their subsequent reports. But let's keep going.
Federation tells us in an email that there are cases in which families said that a suicide was partly due to lack of treatment, but we can't find support for this in the inquiry. That young people take their own lives while waiting for surgery. So why is it in the report? The investigator, a professor of public law, refers us to the secretary, Theresa Backman. I can't answer that. I can't recall that it was linked to the surgical procedure. Because it does say in the section on the minimum age for surgery that young transgender people take their own lives while waiting for surgery. Yes. Why does it say that if you don't have evidence of it? I can't tell you what we wrote and why we used that phrasing. It should have said that young transgender people take their lives due to the conditions they live in. That's unfortunate. It's phrased incorrectly. This inquiry forms the basis of the bill. The bill is criticized by the Council on Legislation, which questions whether it is in the best interests of the child. The bill says the surgery should only be done for extraordinary reasons. The major hospitals say no, there is no scientific basis for sex reassignment surgery on young people. It could increase their suffering. But some authorities are positive to it. There are trans people who consider taking their own lives.
So before we move on to the next phase, it's important to realize what this journalistic investigation uncovered was that the strongest claim for them to remove those safeguards, the idea that people waiting in the queues for surgery are committing suicide because they don't have access to that care, that claim itself is without any foundation when they go and dig down. And that reinforces the idea that when you hear these claims, you really need to say, just pause and ask yourself, is that true? Is the claim real? Is it as strong enough? And then just go back and follow where it came from. Where did you get that data point? Just go back and try to reaffirm that stuff. This is something that journalism should be enabled and empowered to do, but there seems to be this, really contentious minefield of topics and perspectives that you can't cover or promote without being called hateful or bigoted, that is causing our national and worldwide mindset on these issues to have assumptions that may not actually comport with reality. So that was the question of suicide while waiting for surgery. One of the points they made there is that the hospitals say even if you're going to use the justification that we've got to allow the patients have surgery so that they don't kill themselves, the assumption is that if you give them surgery, they'll have the will to live and they won't kill themselves. And that assumption itself is not supported by the evidence. In fact, as we heard Michael Biggs say before, intervening on patients may actually produce the outcome of increased incidence of suicidal thoughts or suicide attempts. And if we don't know that that intervention may not actually worsen the problem, then it's hard to justify it in the first place. And the question is, how far out do you extend that window where you take that suicide and suicidality after intervention into consideration? Because the report that will frequently be brought up in the Ohio hearings is that the Swedish study with the longest term follow-up found that 30 years, if you follow these patients 30 years out, patients who received these hormones and surgeries had a 19 times higher rate of suicide completion. That's not attempts, it's not thinking, it's suicide completion, than matched people of the general public. And so people will say, well, that's not the same population, you can't match it. So just go back in time. If a child, two children, one with gender dysphoria receives watchful waiting, the gender dysphoria resolves, they go on to live their life, they're part of the general public, versus a child with gender dysphoria receives puberty blockers, cross-sex hormones, surgery. In that patient population, a 19 times higher rate of suicidality. That's the type of comparison that we'd hope to make. But because you can't do comparisons that are matched that specifically, it's hard to know how to weigh those things. But that should be a significant data point, because we don't know if these interventions are actually going to prevent that question of suicidality. And there is evidence that the suicidality does not go away and the possibility that it gets worse. Okay, so let's keep going.
There's a study that shows that 40% of these young people have attempted it. Those are terrifying numbers. This can be a matter of life and death. The public debate repeatedly refers to the Public Health Agency's 2015 report, in which 40% of young transgender people said they had attempted suicide. It's a very high number. Danuta Wasserman is a professor in psychiatry and suicidology, and a global expert on suicide. I have difficulty believing that 40% have attempted suicide. In the international surveys, 30% had suicidal thoughts. In the younger age group, 15 to 19, 40% said they'd attempted suicide. So we can't assume that's true? No, we can't. In the scientific world, we say that if you get surprising results, the first thing you do is to verify that they're really correct, that there's no error in method, in interpretation, or that the study population isn't highly unusual. There are very many pitfalls in this type of survey. So, based on this survey, do you believe that 40% of young trans people have attempted suicide? No. The Public Health Agency itself wants to tone down its own.
So when you hear that a study is the result of a survey, that is already a red flag that you need to be cautious about the what weight you give the conclusions and the data from that survey. There are a number of different studies that have made headlines that are based from a survey in which the survey was marketed to an LGBT activism group. There were incentives for people to fill out the survey. There was no way to check whether or not people were adding repeated responses to the survey. And all those different factors don't mean that you have to completely discredit the study, but it just means that you should consider how much weight that you give to the data that comes out of the study. And so I think the take-home point from that, there's when you hear about statistics, about bad outcomes, good outcomes, anything, you should just make sure that you question what type of study was it, because when you weigh evidence, when you look at, as we heard one of the interviewed people say, we need to look at a broad review of all the data, and we need to weigh the levels of evidence. And in any of these systematic reviews, they'll look at data points, but then they'll say, was the study design a really strong study design, such as a double-blinded, randomized, controlled study? That's one of the most powerful study designs, particularly if you can apply it to a large population. Or is it a weaker study design? And among the weakest study designs are personal anecdotes or surveys. And so those are the things where you need to be very cautious about how much confidence you put in the data. And that level of skepticism is what we're seeing reflected in this psychiatrist or suicidologist, as I said. But that data point of 40% nevertheless is being used. And so we're going to explore that question a little bit more.
Its own importance. It's important to apply caution when interpreting these results. The study is a cross-sectional self-report study. It's not randomized or verifiable. 40%, I don't think is, but based on your study, the conclusion is that 40% of young transgender people have attempted suicide. We can draw the conclusion that a large proportion of transgender people are troubled, have suicidal thoughts, and many have attempted suicide. What does it mean if a minister argues for change in legislation based on unconfirmed, uncertain figures? Among young transgender people, 40% have attempted suicide. 40%. It's almost unbelievable.
Now, this is their Minister for Gender Equality, who was vocal in advocating for this legislation, which would lower the age of surgical intervention in kids as young as 15 without parental consent. The journalist tried to get her to be on camera like these other professionals and government officials have been, but she declined. But they used several instances of her using this statistic in support of this legislation, even though we've now found, as they dug through to the people who produced the reports that produced those figures, and found that they were without merit.
And does it matter when it's a group we know have mental health issues? The Minister for Gender Equality declined an interview. What knowledge do we really have about what is beneficial? What can be done to improve their mental health? Several initiatives in different arenas. Schools, social services, society, reduced discrimination, good care in the healthcare system, and thorough assessment and treatment based on the individual's needs. Is there anything in this report that even hints that sex reassignment surgery from 15 years of age would reduce the number of suicides? No, we didn't look at that at all. Does anything indicate it? No, we haven't conducted any such analysis.
Okay, so this is a really important point. There's two aspects to the use of the statistic 40% suicide. The first aspect is that it provides an incentive to do something. 40% of transgender teens have attempted suicide, therefore something must be done. Now, we've already discovered that that statistic does not appear to really stand up to scrutiny. But if we assume that it stands up to scrutiny, the other side of the equation now has to be met, which is that if we then allow them to undergo sex reassignment surgery, which in women would mean double mastectomy, removing the breasts of 15-year-olds, 16-year-olds. It may mean metoidioplasty or other procedures where they construct a fake penis out of skin harvested from other parts of the body. It's a penis that has a cosmetic effect that does not really have a functional effect, and carries its own host of side effects, complications, and can also play a role in future gender dysphoria if it doesn't exactly match the expectations of the patient, which we are learning that it frequently does not. In men, it can mean both castration as well as penile inversion, which is a nice sounding way to say that they will flay the penis open, create a cavity in the pelvis, and invert the tissues to line the cavity. And that's historically how it's described, but that's when a child is allowed to go through full puberty so that the penis gets large enough to produce enough skin and tissue to line the cavity. But since we've started using puberty blockers as part of this therapy, the penis does not actually grow in the way that those surgeries were originally designed to do. And so they don't have the sufficient tissue to line the neovagina. And so they've had to harvest tissue from other areas, and surgeons have been using different types of tissue with various levels of success. They've tried using the tissue from the peritoneal lining. They've tried using harvested colon for it. And, that's where you'll get reports that the neovagina has a smell of stool or feces because the tissue that they are using for it is not designed to be vaginal tissue. It's designed to be colonic tissue. And each of those surgeries have, because these are complex procedures, they carry significant risk factors of fissures, of abscess formation, of the tissues that are placed where they're not physiologically intended to be. And so the body has its own allergic response to them, and they start scarring down and will lose that functionality. So then the patients have to undergo lifelong dilation procedures to try to keep those cavity in place. Like when they say sex reassignment surgery, it's a clean sounding word, but it has all of these very complex things that you have to weigh and consider. Even adults would have a hard time weighing those complications, those options, and to expect a child age 15 to understand those. And that's not even visiting the subject of whether or not they would want to eventually have children themselves and start a family. Those are very complicated things that we're now enabling, if this legislation goes through, 15-year-old children to make those decisions that are irreversible and without parental consent. So that question then, if we allow these interventions to take place, will that reduce the number of patients who consider suicide? Because the assumption is, the second part of that equation is that if we intervene, we're going to reduce the number of suicides. And so the journalist is asking them, is there data to show that that assumption is true? And she says no. So not only is the data point 40% unsubstantiated, but the result, the idea that by facilitating these surgeries, we're going to reduce the suicide is also unsubstantiated. And so that should be a very solid case that despite the fact that people who experience gender dysphoria are troubled, they have many difficult issues, that doesn't necessarily justify that we allow these procedures to go forward in the way that this legislation proposes. Okay, so let's keep going.
The Public Health Agency's study and the government inquiry are both used to argue in favor of the bill. The risk of suicide, both those who consider it and those who do it. The risk is much higher in this group than generally in society.
Okay, so this is the Minister of Health, who basically has been promoting this bill, taking data that was produced by these reports that her government handed her and trying to get this legislation passed because she believes the content of the reports, that there is a significant problem of suicide amongst gender dysphoric youth, and that by facilitating surgery for them, we are going to help them. We already covered how both of those assumptions are unfounded. But the journalists have now got her to sit down for an interview, and they're pressing her on the case that she's made for this policy.
That's common knowledge. No one questions that. Then we can discuss to what degree this reduces the risk of suicide. And are the right individuals getting the diagnosis? But the bill is based on the idea of preventing suicide among young people. if they don't get sex reassignment surgery. Yes, that's one reason, but at the core, my approach has been that healthcare professionals should have the tools they need to care for all, no matter what their needs are. It says there are examples of young people taking their lives while awaiting surgical procedures. If this isn't factual, isn't that important to find out? I can't tell you if this is factual or not. I assume that the documentation I get is correct. The investigators say it's poorly worded, but I trust the investigators. I can't act any other way. I can't tell someone to investigate and give me a report if I'm going to question every comma. However, there are referral bodies who have a say. Yes, how can a minister know that a report has poor phrasing and incorrect data? The consequences can be that measures are introduced that don't help an already vulnerable group.
All right. And that is just really a brilliant example of how this political process that is in the intersection between politics, between families and individuals experiencing difficulties, and the medical profession, and really the dance between all of these about what we as a society allow, is a complex conversation. And so even stateside, when we hear these debates in the Ohio hearings that we will get to, there is this tension where even if you kind of agree with all of the concerns that are raised here, the question of how much restriction on the medical profession should politics have comes up. Should politicians be able to prescribe what procedures medical professionals can do with patients? And that, that's a question that exists even before you get to the question of this particular type of medicine. And so that's something that I think we all have to weigh in our minds. Okay, so let's go to our next slide, if we can get to it.
Treatment.
Okay, and that is, so in the midst of this whole discussion about the complexities of suicidality and these very significant interventions, while they're talking to this expert on suicidology, she makes a fantastic point that I want to cover next. So let's take a look at it.
People are always advised to avoid making life-changing decisions when they are depressed.
I started it prematurely.
Anxious.
I want to start that again. Here we go.
People are always advised to avoid making life-changing decisions when they are depressed, anxious, or grieving. And why would we recommend anything else in this situation? When we know that many trans people have anxiety and deep depression, what help do they need? The evidence clearly shows in suicide prevention that we need conversational therapy for young people before, during, and after puberty. And there are many evidence-based treatments.
All right. So I thought that point was so very well made, which is that, we would recommend in any other context that if an individual is suicidal, majorly depressed, that they do not make irreversible life-changing decisions because they may not be sound of mind at that point. And you could imagine that that type of consideration would have been part of the equation when the Dutch protocol was being designed, where before they would intervene with these puberty blockers, with this surgery, they had to make sure that no comorbid psychiatric conditions were present, because that could affect the decision to proceed with those interventions anyway. And when you weigh that against what we know with the watchful waiting process, which is that a majority of patients experiencing gender dysphoria will desist as they transition to adulthood with that supportive care of watchful waiting and exploratory psychotherapy, that is what we need to be able to compare these things to. if you're comparing it to this notion that there's 40% or 100% risk of suicide, then the weight of your risk-benefit comparison is distorted by something that is not substantiated by the evidence. And that's something that we should be reflecting on as we consider these interventions. Okay, so let's keep going. I think we have been closed down by the copyright police, so I will just finish out with, I mentioned before that when you're a medical professional and you are involved in these therapies, if you start to learn information about perhaps there are risk factors that have not been covered by prior studies that you think should change the calculus of whether or not we proceed with these interventions, if you discover that the strength of the evidence is not as strong as previously found, if new studies come out that show that early protocols maybe didn't paint the whole picture, or if you find that the system that you're in is implementing a protocol that is not using the same patient criteria and selection, but they're using the justifications of the outcome of earlier studies, such as this Dutch study, you may feel that ethical stress, that tension that I'm not sure that I want to be a physician in this environment because we're doing things that I now believe may actually hurt patients, and I cannot in good conscience be a part of that. Some physicians find themselves in a system where the system policy dictates that they have to proceed with these interventions, and they feel they cannot. And so their only option left is to extract themselves from that environment. And there is included a story of that I want to make sure we cover here. So let's go there.
Some doctors believe that young people are treated for gender dysphoria when they actually need other help. We need treatment in which transgender people who need gender-affirming treatment and are helped by it can have access to that treatment as easily as possible. When gender affirmation treatment for youths was set up in Västra Götaland, Angela Samfjord was a driving force. Transgender care is important to her. Yet she chose to leave her position. She met patients with major psychiatric comorbidity, where the risk of incorrect treatment was great. It preyed on her conscience. There is a very clear predominance of the female sex, up to 85%, with high psychiatric comorbidity. 90% have some psychiatric diagnosis. 80% have 2 or more psychiatric diagnoses. 45% are self-harming. 20% have an autism diagnosis, but another 35% had so many symptoms that we wanted to refer them for a full evaluation. When I realized the complexity, I realized that healthcare professionals, despite this, are still expected to okay gender-affirming treatment, despite the lack of evidence that we actually currently have. It preyed on my conscience, and I wasn't prepared to take the risk as a doctor of causing these patients harm. I took the consequence of that and resigned. We also need healthcare that catches the individuals who are not helped by gender-affirming treatment and make sure that they don't get it.
All right. So that was a really fantastic story to include there, because it is not a black and white issue where everybody in the medical profession agrees with the way that these protocols are being implemented. This young doctor that resigned does not believe that no one should ever transition. They're advocating that we need to be very careful about who we apply these transitions to, and that requires further study about the exact nature of this patient population, which patients would benefit from it, which patients would not, and that requires a very, very rigorous scientific application of evidence-based medicine that includes follow-up, that includes accountability, and includes the type of really close scrutiny that we would expect in any other situation dealing with children in particular. So We saw in the Florida hearings that that question of whether we allow research to continue was a sticking point. And the chairman of the medical board said he believed that we should still allow research protocols to take place, even though some of the people on the board said we should put an end to it, full stop. And that is a very significant point of nuance that you want to pay attention to as you listen to these things. So that is the last clip that I thought was really worth revisiting from episode 2 of this series of the Trans Train. We will release on the channel shortly the next episode in the documentary series and have a conversation about that. I think we've lost all of our viewers because of a copyright strike, but the episode should be made available after I do the petition to exclude it for fair use. So in that case, I think we will close down now, but I want to thank those of you who were able to sit through this, and please be on the lookout for future conversations about this important issue as we treat the subject of what to do about children that are having the very real distress of gender dysphoria in their lives. And we wrestle with whether or not certain hormonal or surgical interventions can actually be beneficial, and how we make sure that we're applying the right therapies to the right patient groups to optimize that whole process. So until next time, this has been Talk on Things and Stuff. Take care.